Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes or Lecture. Previous video we discussed till the classification severity of diabetic eye disease. Today we will start from clinical features and must not miss diagnosis. So let's begin with the name of Almighty. So the clinical presentation of diabetic eye disease ranges from entirely asymptomatic to catastrophic sudden blindness. Entirely asymptomatic to catastrophic sudden blindness, eliciting specific symptoms and recognizing pathognomonic clinical signs is important. So we can divide subjective symptoms or patient presentation into three types. So one presentation will be the patient may be having early, meaning mild to moderate NPDR. Second, the patient may be having a presentation with diabetic macular edema. Third presentation, the patient will be having severe NPDR or advanced disease, nothing but PDR. Okay. So in mild to moderate NPDR, the patient is characteristically asymptomatic. He will not have any symptoms. The patients frequently assume their diabetes is under control because their vision remains sharp. Reinforces the absolute necessity of mandated protocol-driven screening programs regardless of the visual complaints. See, because the patient is having NPDR, but still the patient is asymptomatic. That's why this yearly dilated eye examination to an expert by an expert is very important. Okay, very important because it will help us in treating diabetic kidney disease, in treating diabetic neuropathy, in treating in reducing or even in stopping these cardiovascular events also. Okay, then second presentation is like the patient may be having diabetic macular edema. So this is the most common cause of moderate visual loss in diabetic patients. So how gradual, painless and progressive blurring of central vision will be there. So peripheral vision will be spared. So there will be gradual, painless and progressive blurring of central vision. It is the most common cause of moderate visual loss in diabetic patients, diabetic macular edema. So that will be presented by patients like they will be having difficulty in reading fine print and recognizing faces or experiencing metamorphopsia, straight lines appearing wavy or distorted. Okay, that is metamorphopsia. So they will be not able to identify faces correctly. They will be not able to see thin lines properly. They will be seeing straight lines as wavy lines, distorted images they will be able to see. So that is a presentation of diabetic macular edema actually. And PDR, what will the presentation of PDR? PDR presentation depends upon the complication of PDR. So this will present as sudden, painless and often terrifying visual loss. Sudden, remember, here it is gradual, painless, blurring of vision, not loss. Here it is sudden, painless, terrifying visual loss. That is one thing. Second is sudden shower of new floaters. So something moving in front, some balls moving in the front like that. So sudden shower of new floaters, appearance of dark cobwebs or a dense red or black curtain descending over their visual field. So some curtain coming in the front, okay, or sudden shower of some floaters. So like that they present floaters or curtain. So curtain is actually when there is tractional retinal detachment, and floaters they will experience when they will be having vitreous hemorrhage. Remember this one. Vitreous hemorrhage will present as floaters, or if it is massive, then it will present as sudden loss. A patient will not be able to see anything. Curtain is particularly seen a patient will experience in tractional retinal detachment. Okay, so this is very bad thing which is happening to the patient. So three presentations the patient can have. The patient may be asymptomatic and he may be having early to moderate NPDR, and severe NPDR patient may be having some vision loss, some vision blurring like thing they may have in severe NPDR also. In diabetic macular edema, and diabetic macular edema is the most common cause of moderate impairment of the vision in diabetic patients. So they will have decrease in visual acuity actually, and they will not be able to identify faces and identify thin things. Okay, and distorted images they will see. And PDR, they will develop sudden loss of sudden painless loss of vision. Whereas in DME they will have gradual progressive painless blurring of vision, not loss of vision. Okay, Objective signs. So a patient comes with symptoms or he may be asymptomatic. So when so first thing is fundoscopy we do. But before fundoscopy, one thing we should ensure that the patient should not have neovascularization over the iris. So that is also known as rubeosis iridis, meaning neovascularization over the retina. So this should be ruled out actually. So this will present as new vessels on the rim of pupil, okay, rim of iris. So before dilating the pupil for fundoscopy examination, always rule out this rubeosis iridis, otherwise the patient may land up with your glaucoma. The patient may land up with glaucoma. So that is one important thing before going to fundoscopic examination. Always see whether the patient is having neovascularization over the iris. So one thing to remember, that is one thing. So this is one can see microaneurysms like this. Okay, this is the earliest visible sign, or one can see dot and blot hemorrhages. Okay, so big hemorrhages like this, dot and blot hemorrhages, flame shaped hemorrhages like this, flame shaped. Okay, subhyaloid or pre-retinal hemorrhages. So this need to be discussed. So what is pre-retinal hemorrhage? Bleeding trapped between the internal limiting membrane and the posterior hyaloid face. Often it is boat shaped with a flat fluid level when upright. You can see in this image also, it is boat shaped, and here this point I can make you it like this point. This is the fluid level which you can see. So this is dot and blot hemorrhages, flame shaped hemorrhages. So you can see here it is flame shaped hemorrhages only. See, flame will be like this, no, like this flame. Okay, so this here you can make out. So flame shaped hemorrhages and boat shaped hemorrhages seen with a fluid level in your pre-retinal hemorrhage. And pre-retinal hemorrhage, remember, it is a marker of PDR. Okay, hard exudates, you are seeing here, see yellowish type of discoloration in the fundus, and see they are approaching the macula. Maybe the patient is having moderate to CIDME here. So this need to be confirmed by OCT if the patient is having like this picture. So hard exudates will be like this, yellowish, and cotton wool type, whitish somewhat. Cotton wool type, see these are nothing but cotton wool type, no, fluffy type. So these are ischemic spots. These are known as cotton wool spots. Venous abnormalities, venous bleeding I said. So that is nothing but actually dilated tortuous. So the veins are thick and arteries are thin. So these are arteries. Okay, these are arteries, and these thick one is the vein. You can see veins are loaded and they are tortuous as shown by the arrows here. And intra-retina, yeah, here you can make out IRMA very easily. Intra-retinal microvascular abnormalities. You can see this here. See this anastomosis like thing in the retina. Are you able to make out this? Okay, I should take a different color, I think. I'll take blue color. Okay, see here, this type, this one. So this is IRMA actually. Here also you can see one IRMA. Okay, so this is also a marker of severe NPDR. This is also a marker of severe NPDR. So this is IRM actually. So they are anastomosis, tree-like new vessels in the retina. IRMs they are known as. Okay, so if you define them, you can define it as tortuous flat clusters of dilated capillary beds acting as intraretinal shunts around non-perfused zones. Okay, unlike neovascularization, what is the difference between the neovascularization? IRMA vessels do not cross major vessels and do not leak profusely on fluorescein angiography. Okay, that is the difference between IRMA and neovascularization. So they are nothing but dilated capillary beds. Okay, capillary beds actually. So they are present around non-perfused zones. Okay, but they don't cross the major vessels and they don't leak on the fluorescein angiography, similar to coronary angiography. So something called as fluorescein angiography to see the vasculature of your eye. So many patients with early or even moderate diabetic retinopathy have no symptoms. So routine screening is the only way to detect disease early and prevent irreversible vision loss. So subject to symptom, patient will be asymptomatic, or patient can have blurring of vision, or patient may have floaters or curtain coming in front of their eyes. So these may be the some symptoms. Okay, so that depends upon the severity and the type of diabetic eye disease they are having. Now, what not to miss? What not to miss? Not to miss is nothing but the severe form of diabetic retinopathy. That is nothing but the complications of PDR. Complications of PDR. So these are ophthalmic emergencies actually. Ophthalmic emergency. Failure to recognize and rapidly trace the following absolute red flags will result in permanent irreversible blindness. I said number 1, tractional retinal detachment. Number 2, massive vitreous hemorrhage. Number 3, glaucoma due to neovascularization. That is neovascular glaucoma. 3 things. Okay. So tractional retinal detachment. What is the sign? Retina appears in fundoscopy. Retina appears wrinkled, thrown into stark folds, or elevated as a rigid opaque membrane, as you can see here. Wrinkled retina, elevated retina with fibrovascular tissue. You can see blood vessels also. Along with these blood vessels, there is these whitish things is nothing but the fibrovascular tissue which is pulling the retina. So this is tractional retinal detachment. So this is the schematic representation of that. Okay. So this requires immediate vitreoretinal surgical intervention. So what you will do? You will just remove this fibrous tissue by this surgery. Okay. So that is about the not to miss. So this will be the appearance in the fundus. So wrinkled elevated retina with a fibrovascular tissue. Okay. So massive vitreous hemorrhage. The sign will be complete loss of red reflex. Remember when you see through the fundoscope or ophthalmoscope, first you will see a red reflex there. So that red reflex you will not see in the fundus in the fundoscope. So the loss of red reflex. The examiner cannot visualize any retinal details. So when this type of patient comes to you, the patient may be having symptoms like he may be saying floaters, or he may not be able to see only. And when you do fundoscopy, you will not see a red reflex. So the cause can be either this vitreous hemorrhage, or even it can be a cataract also. Okay, in cataract also you cannot see red reflex, no. So you need to differentiate. So you will not see any red reflex. So any patient who is not having red reflex on fundoscopy and he is coming with loss of vision, then suspect massive vitreous hemorrhage or something, a dangerous pathophysiology which is happening, and immediately order B scan ultrasound. That is mandatory to ensure that has not detached behind the impenetrable hemorrhage. So why we are doing B scan ultrasound? So we know that here this is the vitreous tumor actually, and this is the retina. This is the B scan ultrasound. Okay. So vitreous hemorrhage is there, but along with that, whether there is retinal detachment, which is a very bad complication. So here in this picture, there is no retinal detachment. This is an example for B scan ultrasound. So whenever you see an absence of red reflex, you should order B scan ultrasound to rule out retinal detachment. Okay. Neovascular glaucoma. The patient will present with pain in one eye and dilated pupil and pain in one eye, dilated pupil, and reddish discoloration of the sclera. This will be the presentation of the patient. An acutely painful, highly injected, meaning red eye, severe corneal edema, a fixed irregular pupil, and which is not responsive to the light, and an extraordinary elevated intraocular pressure. So this will be the presentation of the patient. See the corneal haziness. This is the cornea actually. See the corneal haziness, and sclera is red here. See, and corneal haziness, and the pupil is dilated. Okay, red eye, corneal edema, meaning corneal opacification, and irregular or fixed pupil. When you measure IOP, if the patient is presenting like this, and the patient may also have associated vomiting also. Remember, because of raised IOP, patient will also have vomiting also. So neovascular glaucoma rapidly induces irreversible optic nerve atrophy. That is a very important thing. Because of increased IOP, so optic nerve head will die. Okay, so that is a bad complication. So rubeosis iris, I said iris neovascularization. That is nothing but new abnormal vessels on the iris. As you are able to see here, see here there are new vessels actually. See these red vessels, okay, on the iris. So what happens when there is, so this iris neovascularization is a pointer that maybe this angle may be blocked by the new vessels, and patient may have glaucoma because of that. So that's why before fundoscopy, always examine the iris for rubeosis before dilating the eye. Okay, so fibrovascular tissue contracts and closes the drainage angle, cynical angle closure, that will lead to glaucoma. So these are the three important complication red flags or must not miss diagnosis in a patient. First, you should rule out these things. Okay, and we have seen what kind of presentation they will have. So loss of red reflex or presentation of wrinkled, pulled retina, okay, tenting retina, and corneal haze, red eye, vomiting, all these things. Okay, if you remember the complication, you will remember the symptoms and signs. What are the differential diagnosis of diabetic eye disease? Yes, this is very important. Okay, so most important differential diagnosis are two things. They are hypertensive retinopathy and central or branch retinal vein occlusion. So these are important one, but other things are also important. There are total 7 actually. Yeah, seven things you need to do, but the most common you need to differentiate are these two: hypertensive retinopathy and central retinal vein occlusion or branch retinal vein occlusion. Others are ocular ischemic syndrome. Radiation retinopathy is also an important differential diagnosis because the presentation is almost same to that of diabetic the fundoscopic findings are almost same in diabetic retinopathy and radiation retinopathy. Okay, ocular ischemic syndrome, diabetic radiation retinopathy. Third is NAION. What is that? NAION, NAION, non-arteritic anterior ischemic optic neuropathy, meaning there is ischemia of optic nerve head, but that is not due to vasculitis. There is ischemia of optic nerve head, but that is not due to vasculitis. So that is non-arteritic ischemic anterior optic neuropathy. Okay. Other thing is pseudophokic cystoid macular edema. Pseudophokic cystoid macular edema. That is because of surgery, a complication of surgery. Okay. That is okay. Then the last thing is sickle cell retinopathy. Okay. 7 things. Okay. So coming to the differential diagnosis. Distinguishing diabetic retinopathy and macular edema from other visually threatening conditions requires a meticulous synthesis of systemic history, laterality, and specific morphological pivot points, important points. Okay. So, hypertensive nephropathy, that is because of systemic hypertension. Points to remember are: it is characterized by prominently arteriolar changes, copper and silver wiring, AV nicking, which are largely absent in early diabetic nephropathy. So what is this copper wiring and silver wiring actually? Copper wiring is, suppose this is the artery, this is the artery. Because the walls are thickened because of hypertension, the arterioles are thickened because of hypertension, and there will be blood which is flowing in this artery. So when you throw light by an fundoscope, so the light will be reflected by these thickened walls of the arterioles as silvery white lines. So that is known as copper wiring and silver lining. So one thing is clear: copper wiring. What is copper wiring, silver wiring? Second thing is AV nicking. What is AV nicking? So normally this wherever there is crossover of artery and vein, suppose this is artery and this is vein, there is no pressing of this vein by this artery. But in case of hypertension, because the veins are thickened, wherever because the arteries are thickened, so wherever they cross over the vein, that vein will it will be like this, nicking, like this. So this part will be nicked by small artery. So that is known as wherever there is crossing, there will be nicking of the nicking of the vein. So the nicking is the vein nicked by artery. Artery is the nicker and vein is nicked. Okay. So that is an important differentiate point early in diabetic retinopathy from hypertensive retinopathy. Okay. And hemorrhages are predominantly superficial, flame shaped rather than deep dot and blot. That is one different hemorrhages. Okay. They are mainly flame shaped in case of hypertension, and dot and blot, they are not present in hypertension. And next is exudates. So exudates may form a macular star pattern rather than that sarcinate ring pattern. Okay. So you can see here, see this. So this is the vein. Okay. And these thin things are arteries. You can see the walls, actually they are shining, copper like shining is there in the walls. So that is copper wiring and silver wiring. Here also you can see thin copper wiring and silver wiring. Okay, so that is one thing. Other thing is, you will not see any dot and blot hemorrhages and all. Copper wiring and silver wiring you will see, and AV nicking you will see. So if I show you AV nicking here, if it is present here, here you can see AV nicking at this point. Okay, so here the vein is passing and the artery is nicking the vein here. Okay, but if you want more detail, you can see, because this is an image, it is not very clear. You can just Google the images. Okay, that's the important differentiating point. So the characteristic of hemorrhages is different, characteristic of exudates are different. They are more of macular start. What is macular start? They are around the macula, they are not circle like. Okay, they are not circle like, they are not circinate ring like. They will be radiating from the macula like this. So macular star pattern like this. They will be not like this circinate pattern surrounding the. They will not be surrounding macula actually. They will be radiating from the macula. You can see in this image only. They will be radiating. They are not surrounding. Okay, so that's one different thing. So that's about hypertensive retinopathy. Now coming to the central CRVO and BRVO. So central retinal vein occlusion causes abnormality in all the 4 quadrants, that you should remember, and branch retinal vein will cause in one quadrant. So that is only the difference between central and branched vein. Okay, now you can see here what happens in that there is a thrombotic occlusion of the central or branch retinal veins. So okay, what is the different point? Almost strictly unilateral and sudden in onset. Fundus exhibits a dramatic blood and thunder appearance with massive confluent hemorrhages and profound venous engorgement. Diabetic retinopathy is typically a bilateral, symmetric, insidious process, but it is sudden, unilateral, and sudden process. Okay, you can see here a lot of confluent hemorrhages in the eye. So it is an example of CRV because it's covering all the quadrants. Central retinal vein. This is also known as a fire in forest appearance, I think, or I'm wrong maybe. Okay, so what is that? Is blood and thunder appearance. Fire and forest appearance, I think it is in central artery occlusion. Okay, so almost always unilateral and sudden onset blood and thunder appearance, massive confluent hemorrhages you will see, profound venous engorgement you will see, and diabetic, it is always unilateral, but diabetic retinopathy is always bilateral and it is gradual. Then radiation retinopathy we will see because it is very much similar to diabetic retinopathy. So there is endothelial damage secondary to ionizing radiation. Fundus appearance is virtually indistinguishable from diabetic retinopathy. It will have exudates, corneal spots, IRM neovascularization. Diagnosis relies entirely on a strict clinical history of prior external beam or plaque radiopathy for head, neck, or ocular malignancy. See, it is very much similar to diabetic retinopathy. Indistinguishable from DR on fundus examination, exudates will be there, corneal spots will be there, IRM will be there, and neovascularization will be there. Diagnosis depends on history of prior radiotherapy. Now moving towards the other differentials. Ocular ischemic syndrome. What is that? Chronic hypoperfusion of the entire globe, meaning entire eye, due to severe ipsilateral carotid artery stenosis. So just to remember carotid artery stenosis. Because of carotid artery stenosis, so whole eye is not perfused, leading to symptoms. So there will be unilateral presentation accompanied by severe orbital pain, because there is ischemia of the eye. So there will be severe orbital pain. Okay, shows mid to periphery hemorrhages and dilated but non-tortuous veins. Microaneurysms are noticeable, sparse compared to classical diabetic retinopathy. Unilateral with orbital pain. Okay, mid to periphery hemorrhages can be seen from mid to periphery. You can see here mid to periphery. Okay, dilated but non-tortuous veins will be there, and microaneurysms, if they are present, they are very much less compared to diabetic retinopathy. Coming to other thing, that is non-arteritic nion. Okay, non-arteritic anterior ischemic optic neuropathy. Microvascular infarction of the anterior optic nerve head. There is sudden, again this is also an infarction. Okay, here it is entire globe, here it is optic nerve head. Sudden unilateral painless vision loss featuring an altitudinal classical lower half visual field defect will be there. Lower half. The defining sign is acute optic disc swelling and pallor, lacking the diffuse peripheral dot and blot hemorrhages that define diabetic retinopathy. So there will be optic disc pallor. Why pallor? Because of ischemia. Pallor and swelling also. Okay. So sudden unilateral painless vision loss, altitudinal visual field defect, that is lower quadrant. Okay, optic disc swelling and pallor will be there. Whenever the optic disc swells, they'll be paler. Remember, lacks diffuse peripheral dot and blot hemorrhages. This is very important point. Okay, so NION, these are real things. Okay, just remember, this is a common thing. Pseudophakic cystoid macular edema. What is that? Post-surgical inflammatory macular edema. Post-surgery macular edema, that also known as pseudophakic cystoid macular edema. Pseudophakic CME. Develops specifically following recent cataract extraction. So differentiated from, so a patient after cataract extraction presenting with macular edema, that is pseudophakic cystoid macular edema. So it is differentiated from DME via fluorescein angiography, which reveals a classical petaloid flower petal leakage pattern at the fovea, unassociated with widespread peripheral diabetic retinopathy pathology. See this is image by fluorescein angiography. You can see the rose petal appearance of this, and this is the fovea actually. This appearance is because of leakage of this dye, fluorescein dye. So occurs after cataract surgery. This will show petaloid pattern and not associated with widespread peripheral diabetic retinopathy changes. Last one is sickle cell retinopathy, vaso-occlusion caused by resicled erythrocytes in the peripheral retina. Important point is predominantly affects the far periphery, unlike the diabetic retinopathy's posterior pole. So classical finding is C-fan neovascularization. C-fan neovascularization pattern extending into the vitreous from the peripheral ischemic border. See, this is the periphery which has a C-fan like this. The C-fan will be like this now. So same type of thing you are seeing here, C-fan, and this will be extending to the center from the periphery. So that is a typical pattern in case of sickle cell retinopathy. Affects far peripheral retina. C-fan neovascularization extends to the vitreous. Diabetic retinopathy primarily affects the posterior pole. It affects the posterior pole particularly, whereas this is present in the periphery. So one clue to, even though it appears difficult, but one clue to remember easily these differentials is, remember it as arterial and venous causes. Arterial and venous causes. See, hypertensive retinopathy is arterial cause. Okay. Here ocular ischemic syndrome is because of artery cause, that is because of carotid artery stenosis. So ischemia to the entire globe. Then ischemia to the anterior optic nerve head, that is NION. Ischemia to the optic nerve head, that is NION. Okay, that is also at arterial cause. And sickle cell retinopathy is also an arterial cause only. So these four are arterial causes. Then venous cause is one thing, that is CRVO and branched retinal vein occlusion, that is venous. Third thing is radiation retinopathy, and fourth thing is inflammatory cause, that is cystoid macular edema because post cataract surgery. So that so four are arterial causes. So remember like this, four are arterial causes, and one is venous cause, one is inflammatory cause, one is radiation cause. So 4, 5, 6, 7. Arterial, venous, radiation and inflammatory cause. So these are the differentials of diabetic retinopathy. Number one among that is hypertension and retinal vein occlusion. Retinal occlusion, ocular retinal vein occlusion, then ocular ischemic syndrome, then your what do you call retinal vein occlusion, radiation retinopathy, and NION, and pseudophakic cystoid macular edema, sickle cell retinopathy, all these things. Okay. Now coming to screening guidelines. Okay. Now coming to screening guidelines. So we'll move fast. Unified guidelines by the American Diabetes Association (ADA) and American Academy of Ophthalmology (AO) for diabetic retinopathy screening. So type 1 diabetes mellitus screening should start after 5 years. Okay. For type 2 diabetes mellitus, screening should start at the time of diagnosis, because 20% of the type 2 diabetes mellitus patient may have diabetic retinopathy at the time of diagnosis only. Screening intervals, regular monitoring should be done annually. Okay. And if the patient has a good control of HbA1c, then you can extend to 2 years also. So this is the screening guidelines. Okay. Now how to diagnose? How to diagnose? What are the steps to diagnose? Okay. So just remember the steps. Patient will present, have clinical examination, then go for advanced imaging, then intervention triage. So comprehensive clinical examination should be done, first one. Okay. Then there will be advanced diagnostic imaging. First comprehensive clinical examination, then advanced imaging. Comprehensive clinical examination, then advanced imaging. So in comprehensive clinical examination, first one is visual acuity testing by Snellen's chart. An unexplained drop in visual acuity worse than 20/25 that is not correctable by refraction. That is not correctable by refraction in the absence of cataracts points strongly to center involved diabetic macular edema. Okay, so blurred vision more than 20/25. Okay, that is not explained by correction of the refraction or presence of cataract, meaning there will be no cataract, there will be no refractory error, but the patient is diabetic and having blurring of vision, and the vision and acuity is more 20/25, more than 20/25, then it is predominantly by CIDME. So after testing visual acuity Snellen's chart, then you will go to slit lamp biomicroscopy. Why slit lamp? So you should rule out rubiosis iris before dilation. Otherwise, this will be masked. After dilation, you will not see neovascularization, because neovascularization will get masked after dilation. That's why, and patient will be more prone to have glaucoma because of this rubiosis. So you will need to do slit lamp biomicroscopy. Then you will dilate the pupil and do fundoscopy. Okay, you will do fundoscopy. Then if you detect diabetic retinopathic changes, then you will have concurrent systemic triage. You will see the kidneys also, diabetic retinopathy, and sensory motor neuropathy, and also you will see, for because the cardiovascular risk is doubled, so you will take steps for cardiovascular screening also. So retinopathy, neuropathy, nephropathy. So DR is a visible marker of systemic microvascular disease. So whenever a patient comes, so first we will see the vision of the patient. So Snell's chart we will utilize for that. So if the vision is not good, then we will before dilating the pupil, we will do slit lamp examination. Then we will dilate the pupil. We will do fundoscopy, and in fundoscopy, if there is diabetic retinopathy or diabetic macular edema, then we will see other systemic things, other things which are affected also, like heart, kidney, and nerves. Okay. Then advanced diagnostic imaging. That was for the comprehensive clinical examination. Advanced imaging are three things. Remember, what are the three things? OCT, optical coherence tomography, the workhorse tool. Fluorescence angiography, so we'll get vascular details by this. B sound ultrasonography, so penetrating view we will get by this. Okay, so which of these should be used when? So OCT is the modern non-invasive investigation of choice for diagnosing, classifying, and monitoring diabetic macular edema. What is the rationale? It utilizes near infrared light interferometry to generate high resolution cross-sectional in vivo histology of the retina. So you will use OCT mainly for diabetic macular edema. Okay, and one more important point is what you will do. You will measure here central subfield thickness, something called as central subfield thickness, CST. You will measure central subfield thickness, and it will dictate exactly when to start and stop anti-VEGF injections. Okay, anti-VEGF injections. You will see CST, central subfield thickness. Okay, you can see here severe, you can see CIDME you are seeing here, no? Okay, now coming to fluorescein angiography. So this is intravenous fluorescein dye is injected and the retina is photographed under UV light. What is the rationale? Fluorescein angiography is unparalleled for identifying occult, non-perfused papillary dropout zones appear dark and pinpointing specific microorganisms that are actively leaking hyperfluoresce to guide targeted focal laser therapy. It definitely distinguishes true neovascularization from IRMA. So to differentiate, if you want to differentiate neovascularization from IRMA, then you can use this fluorescein angiography. And one is the ischemic spots and the leaking spots. You will be able to see microaneurysm will leak and it will shine more, and whereas ischemic spots will turn out black like this, and it will help to differentiate between neovascularization and IRMA. Okay, then comes the B scan ultrasonography. This is utilized strictly when the examiner's view of the posterior pole is entirely blocked by opaque media like massive vitreous hemorrhage or dense cortical cataract. So when we are not able to visualize the backside, so that time we will do B scan. Mandatory to rule out a hidden tractional retinal detachment lying behind the hemorrhage, which would instantly escalate the patient's surgical emergency. See here, I had showed one image before where there was retina was intact. Here you can see there is vitreous humor which is not transparent, and you can see a retinal detachment also in the B scan ultrasound. So where it is done, what is that? B scan ultrasonography in dense cataract, and whenever the red reflex you are not able to see, there you see this. So OCT is mainly for diabetic macular edema and to dictate when to start and stop anti-VEGF injections. Fluorescein angiography to detect minute changes in diabetic retinopathy, and to yes, to detect the ischemic spots, to detect the microaneurysms. Okay, and B scan ultrasonography whenever you are not able to visualize the backside due to hemorrhage or cataract, or you are not able to see a red reflex, there you can see B scan ultrasonography. Okay, so that's about the step-by-step diagnostic. Clinical examination comprehensive, then you will go advanced imaging. Advanced imaging in 3 things. Okay, okay, I think this is enough, and we will study furthermore in the next video. Thank you.